Good morning, I am Dr. Saulina, radiologist from Citizens Hospital and American Oncology Institute. Today I will be talking in brief about radiology in head and neck, CT and MRI in particular. Since this is a very vast topic, I have touched only very few topics and very superficially. So, a quick look at the basic anatomy. If we see, this is the higher sections of the brain as we see on an axial, that is the MR image. This is the central sulcus which you are seeing. Anterior to that is the frontal lobe, posterior to that is the parietal lobe. Coming a little down, anteriorly frontal, occipital lobe, this is the temporal lobe. And the deep grey matter, that is the basal ganglia, the caudate nucleus, lentiform, this is the thalamus. And this dark structure we see is the sylvian fissure, and adjacent to that we see the insular ribbon. This differentiation is very important, as we will see in cases of early stroke. This differentiation is lost, that we will see ahead. Coming a little lower, this is the level of brain stem. This is the midbrain with the cerebral peduncles, frontal, temporal and occipital lobes. And coming a little more down, this is the pons with the fourth ventricle posterior to it, the cerebellar hemispheres on either sides. Then this is the medulla oblongata. This is a much lower section with medulla oblongata, that is the cerebellar hemispheres. Anteriorly you can see these are the maxillary sinuses, the nasal cavity, this is the nasopharynx area. So this is an angio image where we can see the vascular anatomy. The arch of aorta giving rise to brachiocephalic trunk, left common carotid, left subclavian artery. Brachiocephalic again dividing into the right common carotid artery and the right subclavian artery. Both common carotids ascend upwards, divide into ICAs and ECAs. ICAs continue upwards intracranially and divide into anterior cerebral arteries and middle cerebral arteries. The vertebral arteries arise from the subclavian arteries. They ascend upwards, join to form a basilar artery. Basilar artery in turn divides into posterior cerebral arteries. Posterior cerebral arteries form the posterior circulation. So anterior and posterior circulations are communicated by what are called PCOMs, or the posterior communicating arteries. Now these are the vascular territories. Majority of the area supplied by the middle cerebral arteries, which is represented in pink color, which you can see is the lateral aspects of the frontal parietal lobes, the temporal lobes. The ACA territory is the parasagittal portions. This is the central falx, and these are the parasagittal portions of the frontal lobe, the basal frontal lobes, which are supplied by the anterior cerebral artery. Then these are the parts of parietal, occipital lobes that are supplied by the posterior cerebral artery, even the thalami and the midbrain. We can see something in purple. These are the basal ganglia that are supplied by lenticulostriate arteries. These are again branches of middle cerebral artery. This is the venous anatomy. As you can see, the cortical veins, for example, anterior frontal vein, posterior frontal veins and veins of Tolard. These are the cortical veins. They drain into a larger sinus, that is the superior sagittal sinus. Then there is an inferior sagittal sinus here, then internal cerebral veins, vein of Rosenthal. All these drain into the straight sinus. The straight sinus, superior sagittal veins will open into what is called torcular herophily, from which on either sides transverse sinuses pass, and they in turn open into the sigmoid sinuses, that in turn open into the internal jugular veins. So this is a normal venogram which we see. So what is the imaging role in critical care? CT is the most appropriate study. If there is any trauma like a penetrating skull injury or depressed skull fractures, if GCS is less than 13, if patient is having a focal neurological deficit or post-traumatic seizure, the patient is having unstable vital signs. In such cases, CT should be ordered immediately. Patient can be put in observation and later CT can be ordered in cases like short-term LOC or amnesia, disorientations or a GCS more than 13. And MR has a role in follow-up cases of trauma like a subacute or chronic trauma to determine the prognosis, or hypoxic ischemic encephalopathy or diffuse axonal injury, because diffuse axonal injury sometimes cannot be picked on CT in hyperacute cases. When a patient comes with trauma, we inevitably know that we order a CT. When the CT brain is ordered, make sure that a screening of cervical spine is also ordered in order not to miss any subtle cervical spine injuries. And of course, depending on the patient's other signs and symptoms, we can order a polytrauma protocol which can include a CT chest plane, abdomen plane and a pelvis plane. So when we are suspecting a transient ischemic attack, so what is the algorithm which we follow? Of course, we first get a CT or MR done, a plain study, just to rule out stroke. Now once we have ruled out stroke, we have to get a carotid Doppler ultrasound done. But why is that? Because a patient with transient ischemic attack has 10% of such patients can develop stroke in the first 90 days. So it's better to identify if there is any stenosis in the carotid arteries or down below. So if it is negative, then get an echo done to rule out any cardiac emboli. And if there is stenosis, of course, further investigations like MR angio, CT angio can be done to rule out or to identify the level of stenosis and the percentage of stenosis before starting any treatment. And now, if a patient presents with headache, imaging is depending on the clinical history. Like for example, a new headache in a pregnant patient, an MR should be advised. What we are suspecting here is a posterior reversible encephalopathy syndrome, most commonly. Then if we are suspecting meningitis, then we get a CT done or an MR with contrast done. The patient is having a new onset headache in the temple regions, especially. Then if the patient is presenting with intense facial pain, the clinician must ensure that he tells the radiologist to look for trigeminal neuralgia so that the radiologist plans the MR accordingly. Then if the patient is presenting with thunderclap headache, we suspect subarachnoid hemorrhage. For that, CT is done because CT is 90% sensitive to pick up subarachnoid hemorrhage than an MR. Now, if the patient is presenting with unilateral headache that is radiating to the neck, and especially if it is a young patient, we suspect dissection. So, we order an angio along with the CT or MR. What are the critical observations? Any mass lesions, any trauma, stroke, cerebral venous thrombosis, subarachnoid hemorrhage, hydrocephalus can cause mass effect. So what is a mass effect? Any intracranial space occupying lesion can cause a mass effect, and what are the features you can see on CT and MR that we can call as mass effect? First and foremost is a midline shift. So this is the central falx, and we can see here that it is shifted to the opposite side. So this is a contralateral midline shift, that is because of the SOL that is present in the right frontal region. So adjacent sulcal effacement, you see the opposite side, normal sulci, which we cannot see on the site of SOL. Then ipsilateral ventricular compression and brain herniation. And brain herniation, common types of brain herniations will be a subfalcine herniation, where you can see which is associated with the midline shift. Then there is an uncal herniation where the medial temporal lobe is herniated inferiorly. This will have a mass effect on the brain stem. And then a tonsillar herniation where there is inferior displacement of the cerebellar tonsils through the foramen magnum that can again cause a mass effect in the brainstem and spinal cord. Trauma will be dealt as another topic, as I'm not going into any details. Let's deal with stroke, where 75% of strokes caused by infarction, 25% by hemorrhage. So transient ischemic attack, where the patient might present with neurological signs and symptoms which are transient, that is last less than an hour. When you order an MR or a CT, findings will be normal. But transient ischemic attack is important because its warning sign is 10% of such patients might develop infarcts in the first 90 days. So immediate treatment should be started. Ischemic strokes can be divided based on the territory they're affected, like ACA territory, MCA territory, PCA territory, etc., or the mechanism, that is embolic phenomenon or thrombotic phenomenon. Although we can use the word thromboembolic disease because these two conditions usually coexist, and an embolus is a thrombus that is somewhere in the proximal cardiovascular tree. So if you see, for example, in this image on the left, you can see a single hemispheric ischemic lesion. So this could be, the origin could be an ipsilateral carotid artery circulation. And if we see multiple infarcts like this, usually these are border zone infarcts that could be caused by cardiac embolus or global hypoperfusion. Other causes of stroke could be vasculitis, vasospasms, coagulopathies, global hypoperfusions, venous thrombosis. These all are important to recognize because treatment obviously will differ and the prognosis as well. So imaging is thus very helpful in these cases. Now the patient presents with stroke in window period. The protocol is to get a CT plane study done initially to see whether there are any contraindications for administration of thrombolytic therapy. The absolute contraindication is an intracranial hemorrhage, and a relative contraindication is an infarct of size greater than 1/3 the MCA territory. It's a relative indication because it decides the prognosis and the increased risk of reperfusion injury. So early signs of stroke, when CT is done, 60% of infarcts only will develop in the first 3 to 6 hours, and rest 40% cannot be seen in an early phase on CT scan, and all infarcts will develop in 24 hours. So now, as I told you previously, there is loss of differentiation between the basal ganglia insular ribbon, like in this case. You see left side, you can see the caudate nucleus lentiform and the insular ribbon very clearly, which the differentiation is lost, and of course there's a this is the early sign of infarct, and the right MCA is comparatively dense than compared to the opposite side, as if contrast is injected, but this is a plain study. This is because of the hyperacute thrombus that has formed within the middle cerebral artery. And of course, MRI is highly specific and sensitive in detecting an infarct. Diffusion study is the most sensitive method of diagnosing an acute stroke. We see there is restriction. So this is a diffusion weighted imaging. This is the flare sequence. We see flare, there is very subtle changes like some gyral edema, but on diffusion we can see the bright signal, that is the restriction. And this is an angio image that is showing occluded MCA. Post contrast also, there is no significant change, there is no enhancement. So diffusion is a very easy way to pick up an early stroke. Now infarct, they can undergo hemorrhagic transformation, that is called reperfusion injury. This is because of the neoangiogenesis whose capillary walls are very weak and they might rupture and cause hemorrhage. This occurs in 50% of the infarcts. Peak time of transformation is up to 72 hours, and if the hemorrhage is gross, then there might be poor prognosis. Uh, the hemorrhagic stroke, we see there is parenchymal bleed here. This is a CT image that is showing a parenchymal bleed. This hypodense rim is the perilesional edema, and there is a midline shift. So this bleed is causing a mass effect. So based on the location of these hematomas also, we can identify the cause sometimes. Like in suppose there bleed is seen in the putamen, thalamus, pons and medial cerebellum regions. It's usually a hypertensive bleed. And if there is a hemispheric edema in elderly people, it's usually because of amyloid angiopathies. And in much younger individuals, hematomas seen with no underlying risk factors, further evaluation by CT angio needs to be done to rule out any vascular anomalies, AV malformations and tumors. Now, evolution of these brain hemorrhages on CT and MR can be seen as follows. This in this image you can see a subdural hemorrhage that is hyperdense, so that indicates an acute hemorrhage. Now as the hemorrhage progresses, as the time progresses from 4 weeks to 2 days, we see that the hemorrhage becomes isodense, so that is the subacute phase of hemorrhage. And gradually in the chronic stage, that is after 2 weeks, it starts gaining the signal similar to that of CSF, that is it becomes hypodense. So this is a chronic hemorrhage. On MRI, based on the signal on T1 and T2, we can decide in what stage the hemorrhage is in. There is one sequence called gradient echo, in which we call what is called as a blooming, where the low signal is seen. We can say that it is hemorrhage. But a hyperacute bleed will be iso-intense on T1 and will show a bright signal on T2. An acute hemorrhage will be iso-intense on T1 and it will have dull signal or dark signal on T2. In early subacute, hemorrhage will be bright on T1 and it will be relatively dull on T2. Then late subacute, it will be bright on T1 and T2. And in the chronic hemorrhage, it will be dull on both T1 and T2 weighted images. Now coming to cerebral venous infarction, that is caused by thrombosis in the dural venous sinuses or the cortical veins. The common causes are dehydration, hypercoagulable states, pregnancy, infection like meningitis, or from the contiguous sites like mastoiditis, like paranasal sinus infections or scalp infections. Direct tumor invasions, any parenchymal tumors that are invading the adjacent venous sinuses can also cause this. Usually the patients are young, present with sudden onset headaches, seizures and sudden focal deficits. So MR is a better modality, but if a CT is done also, we can see certain changes, like hemorrhagic infarct is most commonly seen, and this also will be seen usually in atypical areas that do not correspond to a single vascular territory. Sometimes these infarcts can be seen most commonly in the parasagittal locations and the temporoparietal lobes. Sometimes only subtle feature that we can find is a hyperdense sinus. This is a left transverse sinus that is dense as compared to the opposite side. This indicates a thrombus that is seen within the sinus. And of course MRI can easily identify. So this is a left temporo-occipital lobe that is showing the area, affected area. The corresponding venogram is showing absence of flow in the transverse sinus, sigmoid sinus and the IJV, that indicates occlusion. But sometimes even hypoplastic sinuses and sinuses with slow flow can also not show the signal on MR veno. So in such cases, other ancillary signs like presence of a hemorrhagic venous infarct can guide us to diagnosis, but however contrast veno is also helpful in ruling out these pitfalls. Next, coming to non-traumatic SAH, as we already discussed, CT is very sensitive, that is 90% sensitive in detecting subarachnoid hemorrhage, and of course prompt CT scan is required because sensitivity decreases as the time progresses, that is it reduces by 66% on day 3. So if SAH is present on CT, workup by CT angio is required to identify aneurysms, AV malformations or dural vascular malformations. We can see in this CT image, this is a plain CT that is showing a large intraparenchymal hemorrhage. These are the sylvian fissures that are filled with hemorrhage. This is the subarachnoid hemorrhage. The cortical sulci also filled with hemorrhage, and this is a subdural hemorrhage in the falx. Additionally, there is also intraventricular hemorrhage and a lot of mass effect. When angio is done, we can see a contrast-filled, well-defined outpouching. That is an aneurysm that ruptured and caused all this bleed. Next is the hydrocephalus. Hydrocephalus is abnormal dilatation of the ventricles, can be divided into communicating and non-communicating hydrocephalus. A communicating hydrocephalus is where all the 4 ventricles are dilated. It might be due to reduced absorption as in cases of intraventricular hemorrhage and increased production as in cases of infection and inflammatory conditions. And non-communicating hydrocephalus might be caused by a mass effect by a tumor compressing over the 3rd or 4th ventricle, thereby causing proximal dilatation of the lateral ventricles. Like in these first 3 images, you can see that all the 4 ventricles are dilated. These are the lateral ventricles, the 3rd ventricle and the 4th ventricle that are dilated. Along with that, we can see sulcal effacement also. And in these 6 images, we can see there is a posterior fossa mass that is obstructing the 4th ventricle, thereby causing proximal dilatation of the 3rd and the lateral ventricles. This is a non-communicating hydrocephalus. This is a pilocytic astrocytoma. Next topic, postpartum lady presents with headaches, seizures and visual disturbances. Of course, we suspect posterior reversible encephalopathy syndrome and get an MR with contrast done. So we see the following changes. The affected areas will show a T1 hypointense signal, T2 and flare hyperintense signal. There will be no restriction on diffusion weighted imaging. Post contrast, there may be patchy enhancement, and angio will not show any occlusions or blocks, but there will be vasospasm of the affected areas, that is posterior circulation. Now this is because in cases of increased blood pressures, there is loss of cerebral regulation, so the blood-brain barrier is affected. So there is vasogenic edema usually in the posterior lobes, like for example the parieto-occipital lobes. The abnormal signal will be seen as white matter edema. So this is a T2 weighted sequence that is showing the abnormal signal. This is a flare sequence that is showing abnormal white matter edema in the occipital lobes. Now we have to consider differentials for this. So when such a image will be seen on MRI, we should consider other differentials like encephalitis. It can be infectious encephalitis, and only way is to correlate with clinical findings and lab findings. Like for example, in infectious encephalitis, we can see fever, peripheral leukocytosis, which are all not seen in cases of PRES. PRES is basically rule out diagnosis, that is we exclude all other diagnoses and then we come to the final conclusion. Similarly, in cases of autoimmune or paraneoplastic encephalitis, a history of malignancy or tumor may be seen. CSF analysis will show antigen specific antibodies, etc. Now coming to the neoplastic processes, they may be benign or malignant. In the presence of a potential brain tumor, what are the factors that need to be considered? Like age. For example, small children in the first decade of life, most common tumors will be craniopharyngiomas, choroid plexus papillomas, teratomas, etc. Then in the 30s to 40s, the most common tumors will be astrocytomas, oligodendrogliomas. Patients in their 40s and 50s, most common diagnosis will be schwannomas, ependymomas, etc. And in the elderly, most common tumors are meningiomas, metastatic lesions, etc. So depending on the age. Next, depending on the location, whether the tumors are intraaxial or extraaxial, they are supratentorial or infratentorial. whether the lesions are solitary or multifocal. Usually solitary tumors are primary brain masses. Some primary brain lesions may be multifocal, like for example lymphomas, glioblastoma multiforme. And most common multifocal tumors are metastatic lesions. And tissue characteristic in the sense, is the tumor having calcification or is the tumor undergoing cystic degeneration, what is the enhancement pattern of the tumor, all these need to be looked into. So most common multifocal tumor, as I told, is METs. They comprise 1/3 of all the tumors. Rest 1/3 are gliomas, and that too most common is astrocytomas, and rest of the 1/3 are non-glial tumors and mostly extraaxial like meningiomas. Now these are axial CT sections that are showing a hyperdense mass with a broad dural base. On post contrast, it is significantly enhancing, showing significant enhancement. Similar mass that is showing calcifications is seen. This is an example of an extraaxial tumor that can be seen on a CT scan. This is a meningioma. On MR, an extraaxial mass can have typical features. This is an example of meningioma. This is a T2 sequence, a T1 and a post-contrast sequence, where it is the lesion is isointense to the gray matter on both T1 and T2. It is having a well-defined CSF cleft. CSF is seen around the tumor. Then it is having a very broad dural base, and this on post contrast we can see there is intense arterial enhancement with an enhancing dural tail. This is a hallmark of meningioma. And if you can see other subtle findings, like the adjacent bone is hypertrophied as compared to the opposite side. As we already discussed, multiple tumors usually are metastasis, and most common mets will be from the breast cancer. Also they can be seen in conditions like neurofibromatosis, tuberous sclerosis, or von Hippel-Lindau syndrome. Most tumors will be hypointense on T1, hyperintense on T2 weighted images, and on CT they will be hypodense, and contrast enhancement may be variable. Now when a signal is high on T1, we should think of hemorrhage, high protein content, melanin, and fat. Once fat is there in the tumor, we have to think about lipomas, teratomas, or dermoid cysts. And calcifications can be seen in tumors like oligodendrogliomas, then craniopharyngiomas, meningiomas, etc. And usually a primary brain tumor will have less mass effect for its size than a metastatic lesion. For example, we can see here this is a right frontal glioma that is causing mild mass effect like midline shift and effacement of the adjacent sulci, but the surrounding edema is not there, as compared to this posterior lesion that is very small as compared to the amount of edema, that white matter edema that it is causing. So usually a primary brain tumor will have less mass effect compared to a metastatic lesion. Some tumors like medulloblastomas, ependymoma will have subarachnoid seedling. So only imaging of the MR brain should not be done. Along with it, a spine imaging should be done in order to stage the tumor for a complete analysis. Then highly malignant tumors usually show diffusion restriction because of their high cellularity. Some tumors cross the midline, for example glioblastomas. MR perfusion is a very important tool to identify the malignant lesions, because high grade tumors have lot of neoangiogenesis. So because of that, there is an increased cerebral blood volume inside these tumors. So this will be helpful in identifying the malignant portion within the tumor, that will help in biopsies, that will help in assessing the prognosis of the lesions. So on post contrast, some tumors, even high grade tumors might not enhance, which may lead to false interpretation of a low grade tumor, but these perfusion studies will help us demonstrate hyperperfusion which is associated with usually a high-grade tumor. Coming to infectious conditions. Infectious conditions, relatively acute onset with the fever, neck stiffness, irritability, headache, decline in mental status, and focal neurological signs and symptoms. CT and MR both can be done depending on the patient's condition. Now, when a CT is done, what are the findings which we are going to see here is there is diffuse effacement of the sulcal spaces, and along with that there might be exudates or some hyperdense material within the subarachnoid spaces or a hydrocephalus, and this is a post contrast image that is showing abnormal leptomeningeal enhancement. So this is a case of meningitis. A meningitis on MRI, if you see, this is a T1 sequence and T2 sequence which relatively appear normal, but on a flare sequence we have to see relative the sulcal spaces should be dark, or that of CSF signal intensity, that is they should be dark, but here they are bright, which indicates that there is exudates within the subarachnoid spaces. Similar appearance will be seen in cases of subarachnoid hemorrhage also on MRI. And post contrast, if we are seeing, this is all the abnormal enhancement we are seeing, and thus diagnosis of meningitis can be made on MRI. Brain abscess is also a life-threatening condition. It is usually in 4 stages: an early cerebritis, late cerebritis, and early capsule formation and a late capsule formation. In early cerebritis, usually a well-defined lesion is not formed. We see only cerebral edema. So this is the area of abnormal hypodensity without any regular margins, and in post contrast there is no enhancement. Similarly on MRI, you see this is the abnormal signal intensity area in the right temporal lobe, and post contrast there is usually no significant enhancement. In the late cerebritis stage, the capsule starts forming as an irregular enhancing rim. The edema is increasing in this stage. In an early capsule formation, we see a well-defined ring enhancing lesion with surrounding edema. Then in the late capsule formation, the capsule becomes very thick and with perilesional edema. So this is a intracerebral abscess. Such enhancing lesions, ring enhancing lesions, can also be seen in other conditions like tuberculomas, neurocysticercosis, or any malignant tumors like GBMs, etc. How to differentiate between an abscess from a tumor? Diffusion weighted imaging is a very important sequence here, because cerebral abscess will show diffusion restriction. You see, this is a ring enhancing lesion with perilesional edema. This is a diffusion weighted sequence that is showing a bright signal. That means this is diffusion restriction. This is seen in cerebral abscess, whereas a similar lesion doesn't show any diffusion restriction in case of a primary brain tumor. So this is how we can differentiate sometimes. Then viral, like herpes simplex encephalitis is the most common cause of viral encephalitis. It can pass through the oral nasal mucosas, through the olfactory trigeminal ganglion cells, transdurally into the brain. When CT is done, sometimes CT may be normal. So treatment should not be withheld, and based on the clinical features, treatment should be continued, because this is a case of a 51-year-old diabetic woman who presented with fever and confusion, and there was a clinical suspicion of encephalitis. But day 1 CT was normal. Even on day 3 CT was normal. Only on day 14 did the hypodensity in the temporal lobe develop. So that is why MR is a better modality of treatment, where we can see affected regions will show edema and diffusion restriction. Like for example, you can see this is a sagittal MR image and an axial MR image showing an abnormal signal intensity in the right temporal lobe. Diffusion is showing few areas of diffusion restriction, and post contrast no significant enhancement. When we see a picture like this and a clinical picture, then we can say that this is a herpes simplex encephalitis. But differentials are like low-grade glioma. Again, low-grade gliomas have a very insidious onset, and there is usually no fever. And some autoimmune encephalitis like limbic encephalitis also can present like this. And acute infarct, of course, focal neurological deficits, and an angio study can show any occlusion, so that is how we can differentiate. Other forms of encephalitis nowadays which we are seeing are Japanese encephalitis and dengue encephalitis. In such cases, similar signal intensity patterns can be seen, but the areas of involvement are usually bilateral thalami, which are usually involved very symmetrically. And we can see sometimes areas of hemorrhage also within them. Now, coming to headaches, if the patient presents with a sudden thunderclap headache, we need to do an emergency CT immediately to rule out subarachnoid hemorrhage, hydrocephalus, or any enlarging intracranial mass. If it is a chronic headache, it's always better to do an MRI. And if it's a typical uncomplicated migraine, no imaging is usually required. Now, coming to seizures, also similarly, if it's a first episode of seizure, CT is performed immediately to rule out any acute process, an intracranial tumor, infection, etc. If it's a chronic disorder, patient can be ordered both MR and an EEG, and both should be correlated, and some common causes should be identified, like for example hippocampal anomalies or cortical dysplasia, so gray matter heterotropias, etc. Now, coming to brain death. Brain death is an irreversible end of brain activity. It's usually a clinical diagnosis. Radiology is only an additional support for the clinical diagnosis. Like on CT, we can see that there is diffuse hypodensity in the brain, there is loss of gray white matter differentiation, and sulcal effacements. And on angio, we can see that there is absence of contrast filling inside the branches of middle cerebral artery, and also there will be no contrast filling inside the internal cerebral veins. And on MRI, similarly, we can see T1 hypointense signal in the affected areas with loss of gray white matter differentiation. On T2, there will be gyral edema, swollen gyri, and diffusion. There may be diffusion restriction in the affected areas. MR angio, similar to that of CT angio, there will be loss of flow signal inside the intracranial branches and the venous sinuses as well. Now, that is in short about a little bit of brain imaging. Now, coming to the neck imaging. Neck will have soft tissues and a cervical cord. So, this is a sagittal MR imaging showing a cervical cord and good amount of CSF surrounding the cord in the thecal sac. Anteriorly, we see the vertebral bodies, and posteriorly the spinous processes. This is a CT bone window imaging. You can see the spinal cord, cervical spinal. Then what are the critical observations in related to the spinal cord itself? It is myelopathies, that is compromise of the spinal cord itself. The causes might be compression, that might be extrinsic compression because of trauma, tumor, or spondylosis, and intrinsic lesions like infection, inflammation, neoplasia, etc. If we want to see bone calcifications, CT should be ordered, and if we want to evaluate the spinal cord, then an MR is ordered. Trauma again be dealt later. Okay, the vascular lesions, two common vascular lesions of the spinal cord will be spinal cord infarction and spinal vascular malformations. Spinal cord infarctions usually are seen in post-aortic aneurysmal surgeries. Patient presenting with sudden quadriparesis or paraparesis. On MRI, we can see an abnormal T2 hyperintense signal area, with showing diffusion restriction, and on post-contrast there is obviously no enhancement. In spinal vascular malformations, again AVMs, they may be intramedullary, that is within the cord, or extramedullary in the pia or the dura, and MRI is the best modality of choice for finding out the AVMs. They can be seen as multiple flow voids, these dark spots, multiple flow voids that represent the dilated venous plexuses within. Degenerative conditions, that is spondylosis, We can see a sagittal MR image of this. This is the C3, C4 level. This is the C5, C6 level. If we see the axial section, this is a normal appearance in an axial section where you can see the spinal cord with good amount of CSF surrounding it. This is the vertebral body, spinous process. So here in this case, there is a disc protrusion that is compromising the thecal sac, the CSF around it, and it's causing mild mass effect or compression over the spinal cord and the nerve root on the left side. Coming to the inflammatory conditions, most common is multiple sclerosis. Multiple sclerosis diagnosis is mostly clinical, and it is a disease of exclusion. Most common feature of multiple sclerosis is waxing and waning of the neurological deficits is the hallmark. It is supported by MR, CSF studies and evoked potentials. So in the brain, MR lesions can be multifocal. They can be white matter lesions, like these are the white matter lesions in the corpus callosum, brainstem and cerebellum. Gray matter lesions in the thalami and basal ganglia, deep gray matter, or the cortical lesions. These are usually larger than 6 mm. They are round and oval with fuzzy margins. And there are certain criteria like McDonald criteria. I will not go into the details much, but that's about multiple sclerosis. Now ADEM, usually how will we recognize ADEM? Usually young children present with focal neurological deficits, signs and symptoms, usually after 4 weeks of post-viral infection or vaccination. We can see there is cord swelling of the cord, then there is high T2 signal within the cord with variable enhancement post-contrast. And if a brain is done, we can see bilateral asymmetric lesions which can range from very small punctate lesions to tumefactive lesions. Now as compared to multiple sclerosis, so basically this is an inflammatory lesion, but compared to multiple sclerosis, involvement of callososeptal interface is unusual. What is callososeptal interface? It is usually the inferior surface of the corpus callosum that is more frequently affected in multiple sclerosis. Next, coming to transverse myelitis, this is also an inflammatory disorder, but it's usually focal in involvement. Causes might be idiopathic, systemic inflammatory diseases like SLE, Sjogren's, etc., or infectious diseases like cytomegalovirus or herpes simplex virus or HIV, etc., and vascular diseases like vasculitis, thrombi, or AV malformations, etc., can cause transverse myelitis. In acute stage, so basically there will be focal cord enlargement. Gradually the cord will reduce in its diameter. There is a bright T2 signal, and on cross section it will be involving more than 2/3 of the area, and there is variable post contrast enhancement. Coming to infectious conditions, what we call spondylodiscitis. Usually 2 types we can see, pyogenic or tuberculous. So pyogenic spondylodiscitis is usually hematogenous spread. So hematogenous spread, so that is why end plates are first involved. End plates because they are highly vascular, and from the end plate the infection will spread to the adjacent disc, and the disc destruction is very early in case of pyogenic spondylodiscitis. So vertebra, this complex is usually involved, and there might be paravertebral soft tissue. So this is the prevertebral soft tissue, and this is the epidural soft tissue which we can see that is causing myelopathy, that is compression over the cord. Unlike tuberculous spondylodiscitis, in tuberculous spondylodiscitis usually the spread is subligamentous. So multiple vertebra will be involved, and usually the disc spaces are spared. Whatever the prevertebral soft tissue, paravertebral soft tissue is there, that is more in cases of tuberculous spondylodiscitis. And the deformity in cord compression is more in cases of tuberculous spondylodiscitis. Here we can see that the vertebra are collapsed, the disc is involved, and there is abnormal signal intensity soft tissue prevertebral region also. And previously we had seen that there is an epidural soft tissue component that is compressing over the spinal cord. Neoplastic processes that can compress the cord, they can be divided depending on the location as intramedullary, intradural extramedullary and extradural. So coming to intradural, most common will be intramedullary, most common will be astrocytomas, ependymomas and hemangioblastomas. So usually these will present as an expansile lesion because they are within the cord, they will expand the cord. There will be low T1, high T2 signal lesions with variable enhancement. Astrocytomas usually involve the entire cord diameter and usually involve longer cord segments, and mostly the cervical cord will be involved. Ependymomas usually have cysts or hemorrhage within them. Intradural extramedullary lesions are nerve sheath tumors and meningiomas. So these are again well defined low T1 high T2 signal lesions. They are usually well defined and they cause widening of the neural foramen. And extradural lesions are most common cause of myelopathy next to trauma, in which most common will be the vertebral mets, and other causes will be primary vertebral tumors like chordomas, giant cell tumors, hemangiomas, sarcomas, or direct extension of the paraspinous tumors like retroperitoneal or mediastinal masses, and hematologic tumors like leukemias, multiple myelomas and lymphomas. So now we can see here that it is a selected sagittal image of the spine that is showing abnormal signal intensity in these vertebra. There is associated vertebral collapse. There is posterior cortex bulging into the spinal canal, and there is effacement of the CSF space that is surrounding the cord. And we can see also that there is mass effect on the cord. So this is basically a case of spinal mets that is causing myelopathy. And most common cause of vertebral mets will be breast cancer, prostate cancers. Prostate cancers are usually sclerotic mets, so signal intensity will be low on all sequences. That was about spine cord in short. Now paranasal sinuses, a quick view of the paranasal sinuses. One selected section at the level of the orbits, we can see this is the ethmoid sinuses, the sphenoid sinuses, these are the orbits. Now we can see here an abnormal soft tissue is seen in the left ethmoid sinuses, and there is a breach in the bone. This is the laminar pressure that's forming the medial wall of the orbit, and this soft tissue is extending into the orbit. That is causing proptosis of the left eyeball, and there are some hyperdense areas within it. So this is a case of fungal sinusitis that is causing bone destruction with intraorbital spread and causing proptosis. Very few cases of the neck. A middle-aged female, diabetic with end-stage renal disease, now complaining of pain and swelling in the chin following submandibular incisor extraction. CT was ordered. What we see on CT was a collection in this area. So first of all, let us see how a normal CT at this level looks like. So this is the mandible bone. Posterior to that, that is the tongue. This we call as the sublingual space. Then there is a masticator space which includes the muscles of mastication like pterygoids and masseter muscles. And this is the parotid gland, that is the parotid space. This is the pharynx. Lateral to it is the parapharyngeal space, and posterior to that is the retropharyngeal space. Then there is a carotid space that includes the IJV and the common carotid arteries. And posterior to the pharynx will be the vertebra. So space surrounding it is the perivertebral space. So when a lesion is seen in the neck, we identify in which space usually that lesion is. Now suppose we see on this CT there is an abnormal hypodense lesion with a thin enhancement, rim enhancement, that is seen in the sublingual space and also in the left submandibular space. So this is basically a collection or an abscess, and this is a Ludwig's angina. Now what is of concern critically is there any airway compromise? Here in this case there is no airway compromise, but we have to look for it. So if there is airway compromise, immediate tracheostomy is the treatment, and then of course aggressive IV antibiotics and surgical intervention might be required. Another case, a 10-year-old female presenting with fever and odynophagia. The CT finding, similarly, if we identify there is an abnormal hypodense collection with a thin enhancing rim that is posterior and lateral to the pharynx. So this is the retropharyngeal space we are seeing where this abnormal collection is there. So this is a retropharyngeal abscess, and even here broad spectrum antibiotics and surgical intervention is required. And so I've gone through very superficially, but because of the time constraints and all, but that's all for now. Thanks.
Thank you very much, Dr. Saujanya, for your elaborate talk. And most of our intensivists are now they can freely communicate. They understood what is needed. They can communicate with the neurologist and neurosurgeons and the neuroradiologist. So at least they understood what to talk about and where to concentrate. And I thank Dr. Saujanya again for coming all the way from Citizen Hospitals, opposite of the very far off from this place. And I invite Dr. Aditya to present the certificate to Dr. Saujanya.